Not sure what's going on with the feedback. And we are live. All right, guys, how is everyone doing? This is Danelle Dixon, Performance Plus Physical Therapy. This is Q&A with Dr. D. This is my series that we've been doing for the past couple of weeks, and I am here with Miss Tameka Duncan. Dr. Tameka Duncan, amazing friend. I'm so excited to have her here. We're going to be talking about rotator cuff injuries, post-operative versus conservative issues, and I have her here, and I'm so excited. Welcome, welcome, welcome.
Thank you. Thank you for having me.
Of course, of course. All right. So, Ms. Tameka, a lot of people don't know you. So why don't you give us a quick introduction to yourself and what do you do when you're interested in rotator cuffs?
Okay. So I am a physical therapist. I've been practicing for 10 years. My experience is primarily outpatient orthopedics. Specialty is treatment of the spine. Love treating post-operative, particularly rotator cuff. But I love treating any and every aspect of the body. But I really do. In terms of post-operative, post-op, rotator cuff is my favorite.
Awesome, awesome. And tell us a little bit about your background, how long you've been a physical therapist, where do you practice, all that fun stuff.
Yeah, so I've been a therapist for 10 years. I'm in Tennessee, so I practice in Tennessee. I have my own private practice, Vitality Sport and Rehab here in Clarksville. So yeah.
Good, awesome. So we're going to get right into it, guys. So I'm going to give you guys a little bit of a rundown in terms of what a rotator cuff is, because as we've been going through the series this week, we've talked quite a bit about different shoulder conditions. I haven't touched on a rotator cuff because I wanted to leave it all for this amazing PT here. So I'm going to give you guys a brief intro to rotator cuff, and then we're going to go straight into questions. If you have questions, guys that are joining me on IG or on Facebook, if you have questions, please post it in the comments. If you have questions either for myself or for Ms. Tameka, if you have anything specific to rotator cuff or shoulders, drop it in. Let's talk about it. We're happy to answer your questions. So for those guys who may not know much about the rotator cuff, you've probably heard that term before, or maybe rotary cuff. Some people pronounce it different and say different things. It's a group of 4 muscles on the shoulder that is responsible for a lot of the very important mechanics of the shoulder. It primarily is responsible for the rotational component of the shoulder and really plays an important part in controlling the mechanics once you get past 90 degrees and you get into that range. All right. And it is probably one of the most commonly injured parts of the shoulder. Would you agree, Tameka?
Absolutely.
Yeah. So I'm just going into a really brief intro in terms of what the rotator cuff is. It's the muscles that sit right on the back of the shoulder blade, guys. And then there's a really big one that sits on the inside of the shoulder blade. The top muscle that you probably heard about is the supraspinatus muscle. There's also the infraspinatus, there's the teres minor, and then the one on the inside is the subscapularis muscle. So those 4 muscles kind of combine to give you the rotational component of the shoulder. And again, as I said before, really control a lot of the very key mechanics in terms of what we call shoulder elevation, being able to lift your arm up above your head. So with that brief introduction, why is the rotator cuff so important to the operation of the shoulder from your perspective, Tameka?
So rotator cuff is so important because the rotator cuff, it basically holds, a simple way of saying it holds the shoulder together. So you have your humerus, which is, that long bone, and it sits right there in that socket. And so the rotator cuff, those muscles are responsible for keeping everything intact. And so, as we know, we can move our arms in various different motions. And so those muscles have to be strong enough and firing in the right way for that shoulder to do what it needs to do. So it's really important because it helps with the overall just basic function of the shoulder.
Yeah, awesome. And to add to that, guys, if you guys remember yesterday's talk where I talked a bit about labral tears. Remember that we talked about that very, very big ball, which is the humeral head, and that very small socket, which is the glenoid fossa. And we talked about how important the labrum is. Well, the rotator cuff muscles are just that added layer of protection that really encapsulates that entire shoulder joint and makes it even more stable, but it's from a muscular standpoint. So it's a really, really key, important component of the shoulder. Tameka, when it comes to rotator cuff injuries, what do you think is the best approach? Or actually, I'm going to go back a little bit and throw one more thing in there. What are the most common ways that people can tell if they have a rotator cuff injury?
Okay. Typically, rotator cuff, let me kind of tilt my screen so you guys can see me. So
Mm-hmm.
typically, rotator cuff, it's that person that has pain. They say, man, the pain is right here. You have a lot of shoulder pain that's kind of right in this general area. And you're going to notice that you may have a hard time lifting. So you can probably get about 90 degrees, but when it's time to go higher than that, it's going to be very challenging. You're probably going to get a lot of discomfort, or it's just going to feel really weak. So it's or when you're trying to lift something, or hold your arm out to reach, you're going to notice that you just don't have the strength to sustain that or to do it. So that's like a common, most common complaint that we'll see in
Mm-hmm.
the clinic.
Awesome. And then, how do we usually get rotator cuff injuries? Is it because you've fallen on something? Do you have to do something to get rotator cuff injuries? Who are the people that are usually getting rotator cuff injuries, and how are they getting it?
You know what? Usually from it's truthfully, it's more of I think a more of a degenerative thing. I think it's just one of those things that as we get older, the body and the mechanics of the body change. And so, as you mentioned earlier, one of the most commonly torn or injured muscles of the rotator cuff is the supraspinatus. And that muscle kind of sits right here on top of the shoulder. So, in everyday life, throughout our entire lives, we're doing a lot of overhead reaching and things like that. So that muscle, if it's weaker or if our posture is poor, that muscle can get a lot of wear and tear over the years. And so just with that, that wear and tear may lead to some fraying of that muscle or some slight tearing of that muscle. Or it could be, God forbid, something traumatic, where it then compromises the shoulder. But traditionally, what you see when it's not a traumatic injury is just the natural wear and tear of the body.
Awesome, awesome. And then when it comes to rotator cuff injuries, what do you think is the best approach? How, from a clinical standpoint, and the patients that you see, how do you like to treat rotator cuff injuries?
For me, I always start with, I think it just depends on their presentation when they come in. For me as a clinician, if somebody comes in and they're really, really painful, my first phase of rehab is reducing pain. Of
Mhm.
course, if they're really painful, then the goal is to reduce pain and then restore range of motion,
Mhm.
as much as we can. So my first goal is to reduce their pain and then start to restore their motion. But in doing that, we then also have to start to strengthen certain muscles. So, when people come in, they're like, you have this all the time. People come in like, oh my gosh, I have this tear, and I think I need to have surgery. And I'm like, wait, hold on. We don't have to go that far that fast.
Yeah.
Let's try to rehab this because we can, you can have a slight tear and you don't have to have surgery. We can rehab you and you can get back. And it depends on what your prior level of function was, but we can rehab you back to function without having to undergo any type of surgery, strengthening the right muscles.
Okay, so let's talk more about that because that's something that I particularly feel very passionate about.
Yeah.
A lot of people will go to a physician or go to an orthopedic physician and they'll get some diagnostics. They'll get an MRI, they'll get an x ray, and the doctor says, you have this, and they get stuck on the picture.
Yeah.
What's your thoughts on treating the picture versus treating what you see in front of you? What's your thoughts on that?
My thoughts on that is okay, you take a picture, I'm gonna see anything. A picture will capture every and anything. The thing is, yes, you may have a tear, but is the tear the source of your pain? You know, I dig a lot. Like again, my background, I love treating the spine, and I kind of use an example of this, not to divert from the shoulder, but you can line up 10 people, and an MRI may show that 7 out of those 10 people will have a rotator cuff tear or a bulging disc or whatever, and
Mm-hmm.
they have one person that's symptomatic. Nothing changed. They all have a tear. They all have
Mm-hmm.
injury, but this one person is symptomatic. So just because it's torn, that does not necessarily mean that the tear or the disc or this it's the source of your problem. So in clinic, a lot of times you may go to a lot. I know the way I practice, and I'm pretty confident. A lot of the therapists I know we practice like this.
Mm-hmm.
People come in with their stack of MRIs and X-rays, and here I want you to see this. I'm like, you know what? Let me do a history on you first.
Mm-hmm.
I don't want to see that, because I don't want that to cloud my judgment, my clinical judgment as a practitioner. Because if I listen to you and I do a thorough assessment, I should be able to get to the source of the problem. Maybe
Yeah.
not, I may not, it could, because it may not be the rotator cuff that's giving you issues. It may be something else. So I can address the source of the problem versus trying to treat a tear or a disc or this. So
Got it. And I love that answer. And guys, just to bolster that, I think the most important thing that you guys need to be aware of is understanding the importance of a good clinical diagnosis. The
yeah,
body is filled and designed to have redundancies. Okay, like that's specifically the purpose of the body. If someone asks you to pick a piece of paper off the floor, at least 15 different ways that you can perform that motion. That's there for a purpose. The body's job is to keep you moving. So even if you have pain this way, there's still at least 5 different ways that you can raise your arm. It doesn't mean that that's the only thing that's problematic. The way that that presents for us as clinicians is that we have to now do the diagnostic work to figure out exactly what the cause of your problem is, because multiple things can cause the same thing. So
mm-hmm.
an MRI is a picture, it's a snapshot in time. It says nothing about your function. It says nothing about what caused your injury or what your prognosis is going to be in terms of what's going to happen in the future. It gives us a good snapshot of what's going on at that point in time, but it tells us none of those other details. We need to go through a clear clinical examination to fill in the gaps, to get the full clinical picture of what's going on with you, so we can figure out A, what's going on, and B, what's the best way to treat it. And I feel very strongly about this with my patients also, that there are lots of times that a patient would do an X-ray and they'd be like, oh, I have osteoarthritis,
Right.
or in my knee or in my shoulder or whatever, and they have a clear cervical radiculopathy.
Right.
And I'm like, well, that's not causing your pain.
Yeah.
So I always say, if that's causing your pain, and guys, for you guys that are listening that are patients, if you go into an exam and your clear indication that you are in the right place is if that person is able to reproduce your pain.
Mm-hmm.
Does it hurt when I do this? Oh, yes, that's my pain, not a pain, because we can make you painful 5 million different ways. Is that your pain that's been bothering you through your daily activities? Then we have identified what's causing your pain, and then we know how to treat it. A picture does not give us that information. So I thought that was a really, really, really good point. All right, moving on. When should someone use physical therapy for their symptoms? Like what should people look for?
I would say so. Whether it be rotator cuff or anything else, I usually say if things aren't getting better within about a week and a half to 2 weeks, it's time to seek some help. So if let's say you've done something and you're having this pain in your shoulder, and you've rested, you've iced it, you've done everything that you could, maybe, and it stops hurting, and then you try to go back to doing activity, and just in 2 weeks this thing is still giving you pain, or it's beginning to get worse, then that's where I say that's when it's time that you seek some professional help. Because really, the sooner you get in, the longer you go, and you irritate something, you can actually be making it worse. So usually the sooner you get in, the sooner, of course, we can then start to problem solve and figure out what the issues are, and start to come up with a plan to restore that function.
Got it. And to piggyback on this, guys, this is something that I'm also passionate about. There are a lot of people that have high pain tolerances, or they think, well, it doesn't hurt that much and I could still do stuff. And the pain is present. They're just able to work through it. That does not mean you're not injured. And it doesn't mean that you're not doing more things to make it worse. Okay. Right. By definition, injury is the presence of some sort of pain that prevents you from doing something well, or as frequently, or at 100%. Right. And if any of those things have changed, even though you're able to push through it and it doesn't bother you, if there's a change in terms of your function, your pain level, or your ability to do something at a certain quality level, that by definition you are injured. Mm-hmm. And by working through that, you are making it worse. So guys, pay attention to that, because specifically when you get older and you're busy and you're running around, you got the kids and you got to do this and you got to go to classes, and you're like, oh, it hurts when I do this, but if I do it this way, then it doesn't hurt. You know, you start finding yourself in weird compensation patterns because, again, as I said before, the body is very efficient. There's lots of redundancies built in there. You will find another way to do it that it doesn't bother you. It doesn't mean that this has gone away. It just means that you found another way to cope and to deal with it. So, guys, pay attention to the duration of your symptoms. 9 times out of 10 will tell you if you have an injury or it's just something that you just slept funny or you did something wonky and it goes away. It will give you a lot of information. When should someone consider surgery with a rotator cuff injury? If they know they have a rotator cuff injury, when is it time to start consulting an orthopedic doctor to figure out, okay, I may need a surgical intervention? What do you think? What are your thoughts on that?
I would say definitely. So my first thought, go to PT. Go to PT first and try to go through a treatment plan with the therapist and consult with your therapist and see. Because again, these are things that we see and we treat on a daily basis. So I would say go to PT first, consult with your therapist. But some of the things that we look for from a clinical standpoint is, it's different things that we look for to see, one, the severity of the tear. So if you can raise that arm up just a little bit, and you're weak, to us that may say, okay, hey, you may have a tear, maybe a little small tear. If there's no complete move, if you try to activate that muscle and you can't move it at all, then that's when we're saying, okay, yeah, something's going on, because you have to think, let's say this is my muscle and it's attached to my bone. If I cut through, I still have some movement. I'm not going to have the same amount of power because the muscle is compromised. But however, if I cut this completely in half, I'm not going to be able to exert any activity of that limb or that muscle. And so as a clinician, we're kind of assessing all of that. We're assessing range of motion. That tells us a lot. Your range of motion tells us what's going on at the joint, what's going on at the muscle. So I would say, like, if there's no active movement, then the PT will say, yeah, we need to get you referred to the orthostat. And then I think after, like, if you try a plan of care with your therapist and it's just not getting better, you've exhausted everything, then you may consult then. But one other thing that I want to have people to think about is make sure every part of your shoulder has been assessed, but also make sure your neck has been assessed.
Yes.
So I told you I love treating the spine.
Yes.
So, I have had numerous occasions. I have a case, perfect example of this. I had a gentleman that came in. He thought he had a rotator cuff tear. PT was the last option. He was like, if it doesn't get better, I'm about to have surgery. I was like, okay, well, listen, we're not going to jump the gun yet. Let's go through. And, basically I did a shoulder assessment on him. And yeah, he was painful, but it didn't present completely like a rotator cuff tear to me. And I just assessed his neck range of motion, like his cervical spine. And I said, let me see you do a couple of things. He was stiff, he was restricted. And so I did some stuff on his neck. Now, mind you, he couldn't get past 90 degrees, as we talked about. Past 90, he was painful, really weak. Looked at his neck, did some stuff on his neck, didn't touch his shoulder. And then I said, okay, let's retest that range of motion. That man was like, woo. I said, you don't need surgery. It was your neck. And so, of course, then at that point, my treatment, we worked on posture, we worked on things for his neck, but then we worked on just strengthening of the shoulder to help with his posture. But I think to kind of go back to your original question, one of the most important reasons why you should consult with the PT is because we can examine the entire system, because the spine is the foundation. So we go back to the foundation. Okay, what's happening here at the foundation? If the foundation isn't right, the house that's built on top of it, or those things that attach to it, they're not going to be right at all. So you could have a surgery, but then, okay, if you don't address the underlying issue, then okay, 6 months, 12 months later, you're gonna feel like you retore your rotator cuff,
Exactly, and I think that's such an important concept for guys to understand. Guys, and again, if you guys haven't looked at some of the previous videos that I put out, take a look back earlier on in the week and last week. We talked about the interaction between the shoulder and the neck. Many times, shoulder pain can it's really coming from the cervical spine. And the reason for that is that if there are issues with the motion of the spine, or more importantly, if there's some sort of compression happening on the nerves, it can do what we call inhibition of the muscles of the shoulder. Everything starts from your trunk or the roots or the cervical or the lumbar spine, and then it branches out into your arms and into your legs. Your shoulders are branched, the neck is the root. If there's something wrong with the root, it's going to start affecting what's happening in the branches. That is why a thorough physical therapy assessment is so key. And you don't want to go with someone who's like, well, just your shoulder. I'm just going to look at your shoulder. We need to look at the entire system to see how one is playing into the other to make sure we get to the right diagnosis and therefore you get the right care. I always tell my patients, once you cut, you can't go back. That's it. True. Right? Like we can't magically undo what happens after surgery, after a post-op situation. So surgery should always be the last stop on the train. Okay, you want to exhaust all of your conservative care options as much as you can before you get to a surgical intervention for anything. Okay, and just to be sure to understand what that interaction is, you do need a thorough assessment. You do want to make sure that one is not feeding into the other. And sometimes it's not a clear-cut idea for us guys. We're treating both because more likely one affects the other. So you want to make sure that you get that really adequately looked at. Okay, Tameka, let's talk. One more question for you. Let's talk about what post-operatively, what are the outcomes? What should patients expect once they've gone through some sort of post-operative care?
Sure. So post-operatively, I think it's important that, some people have this misconceived notion that, hey, I'm going to have surgery and I'm going to be fine right after. Mm-hmm. No. You have to now go through an entire rehab process. So traditionally for rotator cuff, if it's just a simple rotator cuff, I say a traditional protocol would be, depending on the size of your tear, after a rotator cuff surgery, you're going to be in a sling, anywhere from 4 to 6 weeks. What we say, you're not allowed to actively move that arm. Why is that? Because they surgically put everything back intact. And so now over the next 4 to 6 weeks, again, depending on the severity of your tear, that muscle, that tissue has to grow back and attach to that bone. So if you actively move that arm, you can compromise the integrity of that. So the first phase is 4 to 6 weeks in a sling. Every doctor is different. Traditionally, you'll see where your physician may order for you to go to PT for them to passively stretch your arm. Because you can only imagine if you're in a sling for 4 to 6 weeks, naturally your muscles will get tight. The joint will try to tighten up. So you come into us and we just passively take you through range of motion, just to do our best to try to keep that joint as mobile as possible as things are healing. So that's the first phase, traditionally about a 4-week phase. Second phase, now, okay, things have healed enough, so now we can start to put a little bit of stress on that tissue. So now that's where the therapist will start to have you, as the patient, try to see, okay, what are you able to do? Let's use your other arm. Let's do some things to start to reintroduce movement back to that shoulder. So now you have to go through that phase, and then that phase where restoring your motion and then building your strength back up. So that's phase 2. Again, that can last traditionally. Again, it varies patient to patient, but traditionally that's about a 4-week process as well. And then that last phase, and this really depends on your prior level of function, what type of activities you were doing beforehand. But that last phase, that's what we're trying to get you back to whatever that was. So, if you were, at home, traditionally, like we say, we'll see rotator cuff is usually that 60, I say probably 60 and up population, for those under, but let's just say hypothetically 60 and up. So some of those individuals are still working, some may be at home, who knows? But a lot of them they like to do yard work. They like to get in the, garden.
Yep.
So we have to get you back to, can that arm tolerate you shoveling and hoeing and pulling weeds and doing that? Or if you were an athlete, overhead throwing or whatever, we have to get you back to that. So that phase can be about 6 to 8 weeks, again, depending on what that prior level of function is and what we have to get you back to. So a rotator cuff surgery, you can give or take, say that your rehab is going to be at least 3 to 4 months.
Mm-hmm.
At least 3 to 4 months.
Yeah. So guys, so for you guys listening out there, all is not lost if you've had rotator cuff surgery, but there are definite things that you want to pay attention to make sure that you have your full recovery. One of the most common things that I see, at least, Ms. Tameka, is that people don't go through their full rehab.
Oh, yeah.
They go through rehab until they feel like, oh, well, it's fine. I'm not in pain anymore, so I must be fine. And they don't complete the entire thing. Right. Guys, make sure that you get a physical therapist that's going to follow some sort of protocol like what Dr. Tameka just outlined to you. There's specific phases and interventions that you need to do at certain times, what we call a timeline, and specific protocol things that must be followed to make sure that you reach all of those guidelines for that phase of your rehab. At each phase of your rehab, there's certain things that you should not be doing to make sure that you're protecting and respecting the healing timeline of the muscles and of the structures that have been repaired. And then there are also things that you need to be working on so that once you are able to start using those structures, that you have your full range, you have your full strength. The goal is to get you to 100% faster. If you get only to the point where you have no more pain and you cannot functionally use your arm, you've now gone through a surgical intervention for nothing because you can't use your arm. And I say to people all the time, the point of surgery is to get you back as close to 100% as possible. So you need to do the things that will allow you to heal all the way through and get you the strength to where you need to be. And once you have had some sort of surgical intervention, you need to work a lot harder to make sure that you maintain the strength that you had before and even go beyond that so you are able to be functional. Mm-hmm. So guys, don't fall into the trap of, oh, well, it doesn't hurt anymore, so I don't need to go to physical therapy. Can you go by your function? What can you do with that arm? What can you do with your shoulder? Can you lift your kid up and throw them up in the air? Okay. Can you sleep on your shoulder? Are you able to do a push-up? Different things like that. You definitely want to make sure that you are able to be functional on that shoulder so that your surgery is successful. You have not wasted your time. And if you've gone through any sort of surgical intervention, guys, no one's going through that who does not want their full function. So, save yourself the time and the pain and the stress of not being able to use your arm or not being able to wash your hair for 6 weeks that you're in this sling. You want to get your full function back. So make sure you complete your entire physical therapy treatment protocol. Okay. Awesome. I'm just going to look quickly on, we had quite a bit of people here that came on. I did not see. Hi guys, came on. I'm just seeing you guys here. Hey Barry, hey M Dayton, hey Mikkel, hey Mel, Miss Crucian, Miss LaShawn. There's a lot of people coming on. Nice. And I'm going to look on Facebook. If you guys have any questions for me, please put it in the comments. All right. I'm going to see if there's any questions on Facebook. Okay. Tameka, before we wrap up. This was really, really good. Let's see. Man, people are outside. They're like, ah. All right. We got 4 comments. Hold on. This was really, really good. Let's see. How do I get out of this? Sorry, guys. I am technologically a little bit challenged. Do you see any comments, questions for us, Ms. Tameka?
I'm trying to look.
No. They're like, all right, we got 4 comments. Hold on. I cannot see the comments. Hold on. Let's see if I can check it on my computer. Sorry, guys. Bear with me here. I don't see the comments.
I see a couple. I see them.
Yeah, you see it? Okay, great. On my computer. What parameters do you use for consulting rehab? Did you hear that question?
I see a couple.
Did you hear that question?
I'm sorry. No, I didn't.
Okay. It said, I'm just going to take a little bit of a screenshot of it. Hold on 1 second. Bear with me, guys.
I see one of them.
I think you got a lot of questions, girl. You're popular. Hold on. Alrighty, which parameters do you use when adjusting rehabilitation intensity during recovery?
So I think it depends. I think it depends on your orthopedic physician. I have worked with some doctors who as a PT, their standard, like we said, we kind of went through that phase. Okay, all right. If it's just a solid rotator cuff, nothing significant, traditionally about 4 weeks, that's your passive phase. That second 4 weeks is where we start to do active motion with the patient. And then that last phase is where we're restoring movement. However, every physician is different, and you have to ensure that it's just the rotator cuff, nothing else was done. So if the biceps tendon was operated on as well, you may have other parameters that you have to adhere to. So I think first you have to understand exactly what surgical procedure was done, what structures were worked on, so you know what you're working with, because there are different parameters for different muscles or different things that were done. Secondly, I said I think it depends on the orthopedic surgeon. I have gotten patients from various orthopedics. I have one orthopedic I'll never forget when I first started, like my first year. Oh man, I got chewed out by a doctor because I progressed the patient like, oh, they were doing fantastic, and I progressed them like a week ahead of their protocol.
Mm-hmm.
He was pissed.
Oh, wow. Wow.
The patient was fine.
Mm-hmm.
But so you have some doctors, they're like, nope, this is my patient. I want you to adhere to this. But then you have others that they trust your judgment. You've been working with their patients for a long time, and they just give you a traditional timeline. Okay, I want them hitting this mark by this time, this mark, and you progress them accordingly.
Yeah, awesome. I think that's a great idea. And just to piggyback on that, for me, what I do, my first stop for a post-operative patient is to see what the post-op report says.
Yes.
I want to see what structures were repaired. I want to see what has been done. If they've done a different procedure that is different from the script, then it now becomes very imperative for us to consider that within the rehab protocol to make sure that that tissue is protected for as long as it takes to heal.
Mm-hmm.
The second thing that I do is after I do my evaluation, I usually contact the physician and I say, listen, this is the protocol that I'd like to use. This is the parameters that I'd like to set. Do you have any comments on this? So there's a clear line of communication. So we're both talking the same language. So when they see their patients for their follow-up and, the patient says, yeah, I've been doing pulleys, they're like, oh my God, I didn't want you to do pulleys, like you have all of the information up front, because again, guys that are listening, specifically those that are patients that are listening, you want to have a team approach. You want to have your doctor and your PT talking the same language and agreeing on what the best plan of care is for you with your input, of course. All right. So make sure that your physical therapist and your doctor is communicating with each other. The parameters in terms of progression, specifically all the way through rehab, is really patient dependent. There are clear set guidelines and protocols that I go by. Once the protocol is followed, then we can play around with different parameters in terms of how that muscle is rehabbed and how it's reintegrated into the patient's lifestyle in different ways. But we really want to make sure that we're respecting the healing timelines of those tissues as much as possible, because we do not want to compromise surgery. We don't want angry patients. We don't want angry physicians. So our job is to hold them back as much as possible until it's necessary to let them go. Or as I say, now I'm releasing you into the wild. You're out on your own. You can do what you want, but I'm going to hold you back until you're safe. So that's kind of how that goes for me.
That I wanted to say is you have I've had some patients who they have minimal pain. Like they have that, probably that first couple of weeks they have their traditional operative pain, but probably like week 3 for some, it doesn't happen a lot, but week 3, 4, they're like, oh, I feel fine. But again, I think just to piggy off that, what you said is there's still a healing phase that the body has to go through. So just because you don't have excruciating pain does not mean that tissue is ready to be pulled, ready to be pulled on. Yeah.
Yeah.
Exactly. So you'll have to it's still important to adhere to those timelines just to ensure that the integrity is there.
Got it. And we have one more question from Hisa also. Hisa says, how do we educate our patients to adhere to their rehab process? How do you do that, Tameka?
Um, simply by I'm honest with them. I say, hey, do you want to have to go through this whole process again? Because
Yeah.
if you like, especially in that first phase, because that I think that's the toughest phase because you're in that sling and you just want to
Mhm.
move your arm. But again, I think just from day one, if you just emphasize, just reinforce the importance of trying to allow that tissue to heal, because if you compromise this surgery, they're going to have to go back in, repair that, and guess what? Your healing time is probably going to be double, or it's going to be prolonged because now they had to go back in, redo that, and you're starting
Mhm.
all over.
Yeah.
Um, so, yeah,
Agreed. What I do on my side, guys, is I make sure to like communication and education is very key.
yes,
Patients coming into a situation like this, specifically if they've not had a surgery before, they don't know until you tell them. You know what I mean? This is where over communication I feel has been very helpful with my patients. I actually share my protocol with my patients
yeah,
because I think it's very important and it really helps with motivation for them to actually see, okay, at 6 weeks I can do this, because now they can start planning. And it
hmm,
doesn't help them to just have this open ended, well, you can't do this. And there's no follow up on that. If they understand what the process is and
right,
they understand why we have to protect it until 6 weeks and why I can't lift it past 90 degrees until 8 weeks, if
right,
you don't stress the tissues, or why I can't go lifting weights as long as I don't have any pain. If they don't understand those things, then patients tend to be less compliant. So for me, it's been really important to share that protocol with the patients. I give them their own copy, and every time that we come in, on a weekly basis, when we reassess where we are, I'm like, okay, you can do this, you can do this. We have two more things to go on to the next level. We are checking off boxes, guys. You know what I mean? And I make them be responsible for getting to those goals, because once they have a clear goal in front of them, then it's really easy to stay on track. It's easy to manage the emotions of being immobile, specifically for those that are really highly motivated and want to get moving and are very exercise dependent in terms of getting those pheromones and those hormones that they necessary for them to keep happy and keep and to feel good. A lot of people are very dependent on exercise and movement to manage their emotions. So for people that are very exercise dependent, to be immobile for a long time is very difficult. So giving them a very clear goal is so key in managing those expectations and managing those emotions and making sure they get all the way through to the end of their rehab process. Our goal is to keep them on track as long as we can until we let them free.
right.
Okay. I'm just gonna check to see if we have any more questions. Those were some really good questions. Thank you. And I'm
Yeah.
gonna check IG one more time. No, I think we are good. Guys, thank you for hanging out with me. One more question for you, Miss Tameka.
Yes.
How can people connect with you?
So you can connect with me over social media. I'm on
Mhm.
Instagram and on Facebook. You can just type in at Vitality Sport and Rehab,
Mhm.
and I'll pop up. So
Awesome. 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 Well, thank you so much for spending some time with us. I tried to
yeah,
keep you on time because I know you have to run. Guys, thank you for putting in your questions. If you want to connect with her, please message her on Facebook and also on Instagram. You can get her there. She's an amazing clinician. She is based in Tennessee
Tennessee.
and really an amazing clinician, so much knowledge, and just the best person to chat to in any case. So, thank you so much for joining us, Ms. Tameka.
Yes, thank you for having me.
Of course. Bye, guys.